As Professor Kasky was mentioning, I've tried to amalgamate two things into one because I think they are intricately related to one another. One is the whole issue about systematic reviews and the other about meta-analyses. When I'm given to understand that we have a mixed audience here, so apologies in advance if some of the material that I'm going to discuss sounds too basic to you. And again, apologies if some of the discussions that we have right now might sound very technical for the audience here. So I'll try to do a good job of that. So, I mean, it's imperative that I disclose my conflicts of interest because I'm going to talk on a very trial-related subject here. So these are my conflicts of interest. I would like to set the scene by splitting the session into two halves, which I think would make a lot of intuitive sense for most of the audience to follow through. I would like to kickstart by providing some brainstorming around how we actually go about defining systematic reviews and meta-analyses. And then I would like to take you through what the relevance or the role of these two toolkits, as I would call it, in research methodology in the context of randomized controlled trials. I know that both today and tomorrow have been exclusively dedicated to understanding randomized controlled trials, but you will probably get to see what I mean when I distill the facts for you and place before you live examples of how both systematic reviews and meta-analyses in particular come to our rescue even when we are dealing with RCT data. So how would we define a systematic review or a meta-analysis? So why do we use the word systematic before a review of literature when we are talking about systematic review? My personal definition, this is entirely a personal definition of mine, of what I would call as a review of literature is a process. It's an intellectual process whereby we review published or maybe perhaps even some unpublished studies on a select topic, and we collate that information and then critically appraise that. Now, this is with the view of us forming a critical understanding of the subject that we are interested in or a topic that we are interested in. And there are two broad categories in which we can go about reviewing literature. One is, of course, to conduct it very systematically, which is called as a systematic review. And then the other is a more informal process, which is called as a narrative review. I will deal with the systematic review bit first, because I think you will then easily understand what a narrative review would be as a contradistinction to systematic review. Now, there's this very big lengthy definition that the Cochrane database offers us, but I would like to just highlight a few points from this very large sentence that we have. A systematic review is basically a very high-level overview of primary research. So I think these qualities are very important. It's a high-level process. It is not something that should be taken very lightly whenever we embark on it, because we have a purpose in doing a systematic review, and it certainly has to live up to a certain quality. The second thing is we are dealing on most occasions with primary research, by which we mean original studies. It's very unlikely that we would embark on a genuine process of systematic review if we simply want to collect a chunk of previously published review articles. They might nonetheless be very important to inform a lot of our reading of literature, but primarily it's focused on original research, and these are the two important bits about a systematic review. And how do we go about this process? It is actually identifying a key or a particular research question that we are concerned about, and selecting or identifying subjects in a systematic way and synthesizing all the available evidence on that topic in order to answer a very specific question. So that's the whole sum and substance of this Cochrane definition. So if we go into the details of how we go about doing a systematic review, I think the first step in my mind is to ask what we really want to look at. Because a lot of times people do reviews simply because they want to do a review. It's not because they have a burning question in their mind. And one of the key differences between doing a narrative review or a general or traditional review versus doing a systematic review is to be able to actually pinpoint what is the precise research question or gap in the knowledge that we're trying to answer. And that is the starting point of any systematic review. And because we are interested in filling gaps or addressing issues in science which have not been dealt with before, we have to be very stringent in the way we select our studies, and therefore it's imperative that we have predefined eligibility criteria laid out upfront rather than somewhere halfway through the process when we realize, oh, by the way, we need to change tack and change the strategy for that. So I will give you a few examples here. If we are talking about definitions, we need to be absolutely clear within the realm of randomized controlled trials or observational studies and research, systematic reviews or meta-analysis related to that. What exactly do we mean by specific terms? So just to give you a very simple example, because I come from the field of cardiology, it's very easy for me to talk about cardiovascular disease. So if you select a few papers on cardiovascular disease, some papers might say cardiovascular disease to them might mean a combination of myocardial infarction and stroke, whereas other papers might say, look, I'm also interested in looking at heart failure in addition to MI and stroke. There's nothing wrong in that approach, but if you're embarking on doing a systematic review of literature or a meta-analysis, I think it makes a huge difference when we count the numbers of people who develop events. This is especially relevant in the context of meta-analyses. And therefore, being clear in our own heads about what we mean by the outcome definition or the exposure definition is absolutely critical when we conduct systematic reviews and meta-analysis. And I can show you any number of examples of badly conducted reviews and meta-analyses where they've combined apples and pears together. And no surprises about the end results. They tend to be quite heterogeneous. And that's one of the most important bits whenever we embark on doing these reviews or meta-analyses. Again, a stringent adherence to both the inclusion and the exclusion criteria forms the fundamental basis of these two toolkits that we use in research. Now, just to lay out a few examples before you, I might be interested in studying the effects of a particular therapeutic agent in a particular age group of patients because I might personally feel that that is the age group that I am seeing in my clinic or in my hospital more commonly. But whereas if you look at published literature on that field, we might actually encounter that the age range of the participants included in the relevant randomized controlled trials might be either much wider or much lower or much older. So I think the decisions regarding how we select studies for inclusion into a review or a meta-analysis has to be very carefully thought upfront before we do the search. Again, one might decide, I want to restrict my reviews or meta-analyses to studies which are published from or European countries only, which is a fair point because if you're dealing with largely a homogeneous population, we would rather want our results to be applicable to local policy guidelines rather than be applicable to the world over. Now, a counterpoint would be that whatever results one might get from a systematic review or a meta-analysis which is highly focused on a select group of individuals within parts of the world may not necessarily be generalizable. So again, we have to bear in mind what is the fundamental research question. Are we trying to answer some generic research questions which might be applicable across the entire humanity, or whether are we very keenly focused on developing local guidelines or national or regional guidelines, for which again the selection criteria will be entirely different for the review or the analysis that we do. The other important thing which I think is very relevant, now this is particularly relevant in randomized controlled trials, and again going back to the field of cardiology, I think if you look at the pre-statin era and the post-statin era, and if you want to combine randomized controlled trials into an evidence synthesis, for example, sometimes based on the cut points that we choose for the calendar period in which they were published or coming out into public domain can make a huge difference to the results that we see. Now, one might observe, for example, the event rates for cardiovascular disease in clinical trials or observational studies of cardiology have been much higher before the introduction of statins or the introduction of the novel revascularization therapies. And therefore, choosing the right points in time where we go about selecting the relevant articles is equally important. And the final thing which I would like to say about the systematic review is that it is something which most of us do not appreciate when we start out doing these reviews or analyses, is the evaluations, objective evaluations of study quality. Increasingly, most of the big journals are asking us upfront for what were our search criteria, and apart from that, what were the criteria that we actually used to rate or score individual study qualities. There are any number of scoring systems available widely right nowadays. Anything which is recommended by the standard journals should be fine. But I think that is something which should form a key part of the way we do systematic reviews. One thing which we should probably not misunderstand or mistake a review from a meta-analysis is that a systematic review is never meant to be a process whereby we get quantitative answers. And that's something which we have to bear in mind. What a systematic review does allow us to do is form a generic but a well-informed decision regarding a research topic. What it does not give us is numbers that we might want to use for, say, for example, policy formulation or to calculate rates or disease estimates. And there might be two reasons why that might not be happening in the case of a systematic review. The first one is because the studies may not have actually reported odds ratios, hazard ratios, or relative risks, which are the bog standard estimates that we use in meta-analyses. Alternatively, the studies may be so different based upon the inclusion criteria, based upon the population study, based upon the interventions used, that it is probably not wise to combine those numbers because we will still end up getting a lot of noise. But nonetheless, in order to form a generic impression, it is wise to do a systematic review and stop it there rather than meta-analyze all the findings of individual studies. So the whole purpose of doing a systematic review is to avoid bias. And that is perhaps one of the reasons why we are very stringent when we do systematic reviews as opposed to narrative reviews. And the reason why we want to be stringent is because sometimes what we publish in science can have a huge impact on medical practice, public health policy, and preventative policies. We don't realize that very often when we publish our papers and go out to the press trying to trumpet our scientific findings, but we as a scientific community or a medical community have a huge responsibility to come out with information which is reliable and which can stand the test of time. And for that reason, systematic reviews are meant to be conducted to a very high level of standard. So going back to what a narrative review, I suppose it becomes very clear in the mind of this audience what a narrative review holds as opposed to a systematic review. This is the traditional process of review articles that we tend to read widely within literature. And generally, I mean, there's a belief that people who embark on doing these publications or write these reviews, they tend to be experts in their field. But the whole process of going about collecting information, collating studies, is a more informal, unsystematic way. And sometimes there can be an element of subjectivity to that, so that it can introduce personal, professional biases, maybe some conflicts of interest as well, based especially in the field of randomized controlled trials. If I'm more in favor of a particular group of medications, say for example, a drug company has sort of trumpeted its own brand of statin into my ears, then maybe I'm more inclined, or maybe I may be more inclined to providing data which seems to favor that particular brand or that particular molecule. So we cannot avoid these biases in a narrative review, and that's something that we should all be very wary of. So whenever we look at narrative reviews, one of the key points to make note of is what is the standing or academic standing of the person who has published that review. Number two, what are the potential conflicts of interest of that particular individual or the group of individuals who has published that paper. And certainly number three, are they anywhere close to maintaining at least decent standards in terms of the information that they have collated and the way they have unbiasedly presented the findings of a review. Now, I think the natural extension of a systematic review is a meta-analysis. That's what one would have thought, but that's not necessarily the case. That's something that I would like to impress to this audience. When we embark on a systematic review, the whole business of getting together a few studies or several studies focuses on one particular theme. Unfortunately, a meta-analysis it simply means a statistical combination of two or more studies to provide a single summary estimate of risk or hazard. So that, by definition, need not necessarily be systematic. But what would be absolutely crucial if you want to publish a good quality meta-analysis is to precede that with, or marry that with a properly conducted systematic review. You would be surprised to see a lot of meta-analyses in literature which churn out numbers, but the numbers don't mean anything if the whole process of study selection and inclusion is already biased because of the prior beliefs of the authors. Now, one of the things that we have to also remember is in meta-analyses, it's not the individuals that count when it comes to publishing the net findings. It is each study is actually treated or regarded as a unit for the analysis, but that is more of a technical detail rather than of a practical relevance here. And what we tend to see in most meta-analyses is a summary level estimate. I will give you some examples. I'll show you some examples which make things more clear. And then the corresponding confidence intervals which give us an error margin. So just to illustrate this, I'm not sure if this is visible from behind. Do we have a laser pointer? Suppose we do. It's just the mouse, okay.
There is a laser pointer anyway.
Yeah, that's fine.
But there are TV sets over there, so they won't be seeing what you...
Okay. So I suspect if we look at this, this is just an example of how a standard meta-analysis looks like. Apologies once again if I sound very basic to audience who are very much familiar with this field. But this is what we generally call as a forest plot. Don't ask me why it's called as a forest plot. I've heard many people give many views about why it's called forest. Some people have said it's eponymous, named after somebody, which I don't think it's true. Others who are experts in the field tend to say that if you look at it from the top, it's like you're flying over a forest and maybe you're seeing a row of trees. But again, I can't vouch for that. Apologies. So just to show you this is a very simple example of how a forest plot of a meta-analysis would look like. Now what we see here is a bunch of clinical trials which have done a similar type of which have studied a similar type of a disease outcome, which in this case was the risk of non-fatal myocardial infarction in people who have been randomized to more intensive glucose treatment, which is here, versus less intensive glucose treatment, or the standard of care. Now, as you can see on the left-hand panel, we have a list of all the studies here, and what we have shown after that is the number of participants in each individual study. So you can see that there's a small slash, which means that these are participants both in the treatment arm by the control arm. So there's a difference, for example, in the UKPDS study, in the number of people who are randomized to the active intervention versus the control. Whereas in most other studies here, down this row, there's an equal number of people in the treatment arm as well as in the control arm. So this is something which is of fundamental importance whenever we try to do a meta-analysis. How many patients were randomized into the treatment arm? How many were randomized into the control arm? The next important bit when we try to pool these information is the number of events. So the number of participants in each study and the number of events, because this is basically the head count that we're interested in. And again, just to illustrate here, in each of these studies, we have separated the number of events by the treatment arm. So 221 events occurred in the active treatment group in UKPDS compared to 141 events in the control group in that particular study. And what we see here, this is just a diamond. This is just a standard representation. One could have chosen any other representation, but this has been a traditional way to represent the findings of individual studies. So all these diamonds and the horizontal bars are the so-called effect estimates, in this case the odds ratios for individual studies. And what we see, the bigger diamond at the bottom, is a summary estimate or the pooled estimate, which means this is the statistical combination of the effects of individual studies that we have demonstrated here. Now, what this particular central square or diamond represents is the effect estimate or the point estimate for that particular trial. And what this tells us is this is the pooled or the combined estimate for all studies taken together. Now, you see that there's a black line here, which corresponds to number 1. This is called the null line, which means if studies, along with their 95% confidence intervals, as we have used in this particular analysis, fall very clearly onto either side of this null line, it may indicate either that the intervention is protective if they happen to be on the left-hand side here, or they might increase the risk of an outcome if it's on the right-hand side here. And this is very clearly depicted by the odds ratio and the corresponding 95% confidence intervals for each of these studies. Now, as you can see, in this particular instance, the pooled estimate is about 0.83, and the confidence intervals are 0.75 to 0.93. Now, the way to interpret this is that the odds of developing non-fatal myocardial infarction in people who have been randomized to intensive glucose treatment is 17% less compared to people who have been randomized to the standard treatment. Now, the other thing is, if we look at the pooled estimate here, we can see that it's clearly onto one side of the null line. And again, it's worthwhile looking at the confidence intervals. It's very clearly under number 1, which means there's a clear benefit for protection for intensive glycemic control with regard to non-fatal myocardial infarction. It could be different for other outcomes. Again, that is why we have to be very specific about the outcome and be very specific about what the exposure is in each of these trials. So one might wonder, why would we really want to go about doing systematic reviews and meta-analyses, and how do we do them if we are interested in doing? Now, I think the how bit would probably be discussed more in depth tomorrow in the methodological workshop sections, which I'm looking forward to very much. And what we can do now is actually brainstorm about why we actually go about doing it and how do we do them, and when do we do them. So again, the basic questions that I'm trying to ask is, why should we do meta-analyses of RCT data? Now, I'm sure you've probably heard through the rest of the day's discussions that RCTs offer the gold standard of evidence. They are perhaps at the pinnacle of evidence if you look at different types of study designs. And the beauty about randomized controlled trials is that they incorporate in their own study design effects which can completely knock out confounding. Now, the beauty again is that they not only get rid of the known confounding factors, but also unknown or unmeasurable confounding factors if they have been well randomized and if the protocol has been adhered to very strictly. So I think that's the beauty of randomized trials. But that begs the question, why should we bother at all doing any systematic review or meta-analyses of RCT data in particular? I can see a value in combining observational studies, for example, but why should we bother in the current day and age when most of the clinical trials are conducted to a very stringent protocol and standard? Why should we bother doing a combined analysis? I think these are some of the salient features why we should probably considering doing a meta-analysis of RCT nonetheless. The first thing is, of course, in my view, to resolve uncertainties which emanate from individual studies, especially if they have been conducted in a historical context many years ago, many decades ago, and still there is a lingering debate about whether or not the intervention is effective or otherwise. I think in that situation, there is absolutely a value to conduct a meta-analysis to increase the robustness of the findings and to be greatly certain about the value of the effectiveness of a given intervention. The second important reason in my mind is we can improve the precision of the effect estimates, especially in key patient subgroups, by which I mean people who differ by age groups, people who differ by gender, people who may be hypertensive versus non-hypertensive, smokers versus non-smokers, diabetics versus non-diabetics. If we sort of dissect the data down to those individual groups of patients or participants, I think overall, if there is a small clinical trial, it might not be able to give us enough confidence about whether or not an intervention works or does not work within individual subgroups. And that's where meta-analysis would be of a great advantage to do. The third reason is to actually collate and critically appraise all the evidence that we have to formulate clinical guidelines. And this is of immense importance worldwide, especially in most countries where there is a huge funding pressure in public funded healthcare systems to be able to tease out which is the intervention which is not only effective clinically but also perhaps even cost effective. Now this is particularly relevant in the UK context where most of the healthcare is free and public funded. So I think there meta-analyses have got a very well defined role in trying to reshape the way we look at the clinical guidelines. And of course, one of the less appreciated facts about meta-analysis in the context of clinical trials is that they provide perhaps one of the earliest signals for a harmful effect of an intervention. I mean, whenever you see a clinical trial published in literature, everybody talks about the fact that the intervention has worked in a given population. How often is it the case that we come across people declaring that this intervention, by the way, has got 100 side effects? That's seldom the case in most of the studies that are initially coming out in big journals. So that's precisely where meta-analysis can actually provide what I would like to call as a reality check for the findings of big clinical trials and say, hang on a minute, there's probably a signal for harm in this particular direction. Have you figured that out? What is the likely cause for this and what do we do about this? And I will show you a few good examples of that, perhaps extreme examples of that. And I think this is something which I particularly am greatly fascinated about. A lot of people think that randomized controlled trials are perhaps the end of the road in research because you've done it, you've nailed the hypothesis, you've shown that an intervention works, and that's the end of it, proven, nothing more to do. But I would challenge that view. I would say, I will show you a very classical example of some of the work that I've been involved in, where in fact it was a randomized controlled trial, meta-analysis, which gave us food for thought to go on and do some more basic science related work, which I'll show you in a second. So going back to each of these individual areas, to resolve uncertainties is a great advantage of meta-analysis, especially when individual studies have been underpowered or whenever they have shown disparate findings. Let's take an example here. Let's go back to the slide that I showed you a few moments ago on the effect of intensive glycemic control. So if you look at this plot, if you were a cynic, you would say that of these 5 studies, 1 and 2, only 2 studies are clearly onto the left-hand side of this null line, which means only 2 studies actually have clearly on their own right shown that an active intervention of intensive glucose lowering is beneficial in preventing future heart attacks, non-fatal heart attacks. Now, all these 3 studies, none of them were probably having power enough to prove that hypothesis. But when we combine all these 5 very large clinical trials, what we do get is a very clear signal for benefit. So that's what I mean resolving uncertainties in literature. And this is where meta-analyses, I mean, I haven't shown the I-squared value here, but certainly you can take my word for that. It was a low heterogeneity statistic. And that's why when we came out with this publication a few years ago, people were amazed at the fact that overall there's a good protective effect against non-fatal MI with more versus less intensive glycemic control. So again, going back to the precision of effect estimates of association. Now this is extremely important if you really want to fine-tune the guidelines and more for regulatory reasons. For example, if the FDA wants to approve a given drug for people with a low heart rate versus a high heart rate, I think meta-analyses can be a boon for them to bank on to formulate those decisions. So this is, for example, the most classic paper that I can cite on cholesterol-lowering medications from the Oxford group. This is the cholesterol treatment trial is individual participant data meta-analysis. We will go into the differences between literature-based summary level and individual participant data meta-analysis tomorrow during the workshops. But just to show you a summary here the basic question was, everybody knew by 2005 when this paper came out that it's a no-brainer that cholesterol lowering improves your cardiovascular risk profile and benefits you from getting future heart attacks and strokes. But what was not entirely clear was, if we start cholesterol lowering medications in people with a very high baseline cholesterol to start with versus people who have actually more or less the normal range of cholesterol levels, would that still make the difference? And I think if you look at this plot, what they have very nicely demonstrated here is, on the left hand side, they have grouped individuals into different categories of total cholesterol, LDL cholesterol, HDL and triglycerides. And what this particular part of the figure suggests is, if you look at the point estimates, the protective effect of LDL lowering per millimole per liter reduction in LDL cholesterol is same or strikingly similar across the board for almost all ranges of different subtypes of cholesterol. And you can see now the chi-squared statistic is one of the older generation of heterogeneity statistics. It preceded the I-squared statistic, if you like. And so again, the p-value for the heterogeneity, which means this is a test which is asking the question whether there's any statistically significant difference between these effect estimates between people belonging to these different subgroups, and the answer clearly is no based on these data. So this is where we have a very clear example of massive amounts of data precisely telling us that regardless of which category of cholesterol, LDL, HDL or triglyceride you belong to, the benefit of statin therapy is very strong. And that's one thing which is like a big take-home message from the study. So touching on the point of identifying signals for harm, I would like to just illustrate this by two examples which come to my mind. One is the rosiglitazone story. Now, previously, the Food and Drug Administration in the United States was never very stringent about how anti-diabetic drugs got approved for clinical use. Now, this is primarily because most anti-diabetes medications, one of the key endpoints that people were interested in looking at was obviously what is the effectiveness in the reduction of glucose values or HbA1c values for that matter. So it never occurred to people that, okay, we should be looking at the signal for harm in most of these anti-diabetes medications. So what Steve Nissen and just one other co-author published in 2007 alarmed the world, simply because what it suggested was, if you combine small clinical trials on this topic with two very large clinical trials, there is a signal for harm. Now, this particular estimate suggests that there's a 43% excess risk of acute myocardial infarction in people who have been randomized to receive rosiglitazone. Now, henceforth, there was a lot written and talked about and discussed in both in the lay press as well as in the educational media. And ever since, the FDA has actually issued a warning and said that for any new drug of the anti-diabetes class to be approved, it's mandatory that they have to show, either through combining it in a meta-analysis or through detailed subgroup analysis, that there is no signal for harm. So this is simply a literature-based meta-analysis. If you read Steve Nissen's conclusion on that paper, he openly acknowledges that this is basically a summary level meta-analysis, but look at how even a summary level meta-analysis can potentially change the way we think about using common medications like anti-diabetes treatments. And this is something which I have been involved in. Statins are one of the wonder drugs of the current day and age. But there was this question raised in some of the individual randomized control trials that there might be a signal for increased risk of type 2 diabetes. Nobody knew why that was the case, and nobody even knew whether this was a genuine signal for harm or whether this was just a one-off random number that got generated in one of the clinical trials. So what we tried to do then, we teased out this debate apart in 2 steps. The first step, we said, fine, let's combine all the clinical trials which have used statins and have addressed the risk of, or reported on the risk of incident diabetes. So as you can see, there's quite a lot of noise here, or at least it looks as if all these studies are on both sides of the null line. There are 2 things which strike us. One is, most of these studies individually did not have power to answer the question whether using statins in short term or in long term can increase the risk of an individual developing diabetes in future. Because as we can see, the confidence intervals overlap the null line, which means in those individual studies, there was no power to actually say with a great deal of confidence that this intervention caused harm. But when we combine all these data into one particular meta-analysis, you can see that this little diamond is clearly onto the right-hand side of the null line. Now, if you look at the summary estimate here, it reads 1.09, which means in people who received statin treatment, there was about a 9% risk, 9% excess risk of incident type 2 diabetes. The risk could have been as low as 2%, which is what is the meaning of 1.02 is, or worse, in the worst case scenario, it could have been as high as 17% excess risk. So if you look at the world population, early in 2000 and towards the turn of the century, it was estimated that about 6% of the world's population was having type 2 diabetes. And I'm sure this audience is aware of the fact that type 2 diabetes is a known risk factor for heart disease and stroke. So you would expect most of them to be on statin treatments. But what about people with prediabetes? A lot of prediabetic patients, if they have other risk factors for vascular disease, are also put on statin treatment. So the way it works is, if somebody with prediabetes or no diabetes at all in the past has been treated with statins for long term, there was, on a population level, certainly an increased risk of developing type 2 diabetes. And this is what this study actually illustrated. And we didn't stop there. What we did was, we asked the next level of question. Okay, it's one thing to say that statins increase the risk of your diabetes, but what if some people selectively get a high dose of statin versus a standard dose of a statin? And again, the answer was not any surprising to us. So we combined, again, some of the published as well as unpublished data in this particular case, because by this time, most of the people involved in statin trials got very excited about the findings that was reported previously. So what we did was, we did an international pooling exercise. We got in touch with the principal investigators from both across the Atlantic and here in the UK. And some of these results, I'm sure, would never have been published in the past. But because this was such a burning question that had to be answered, most people said, fine, we will pool the data, we'll pool our efforts. And the answer is this. If you use more intensive statin treatment, the risk of incident diabetes goes up by 12% compared to people who are using a standard dose of statin treatment. So this, I would say, is a very good example of using a simple technique like meta-analysis in a very sensible manner to answer something which has never been thought of before. It might not be a disease outcome which has immediate bearing on patients who develop diabetes. But if you look at it in the long run, certainly a lot more people are likely to remain on statin treatment for many decades. And this is certainly one of the red flags now, if you look at any of the FDA labels on anti-diabetes medications, especially statins. Hypothesis generation. As I said, this is an area which has fascinated us from as a one, if I can use the word, one very surprising extension of the findings of trial-related meta-analysis. As I mentioned before, a lot of people think RCTs are a dead end, and there's still another group of people which thinks meta-analyses of RCTs are a dead end. But I think it's not a dead end. It's probably an end for the trial-related work itself, but it's never an end for the science behind the clinical trials. So just to illustrate, borrowing on from the previous examples where we showed that there was an increased risk of diabetes in statin users, we then asked the next question, okay, to what extent is this risk actually an off-target effect of statins, and to what extent is this a non-target effect? So by which we mean, is this actually mediated by the HMG-CoA reductase pathway? And what we then did was a Mendelian randomization experiment. And then in this, we clearly showed that if you have a G allele for this particular allele on the HMG-CoA reductase gene, it increases your risk of diabetes by approximately 2% on average. Now that might seem a very minuscule risk, but this is what we would normally expect on most of the individual SNPs, but the p-values for these are highly significant. So this was a natural extension of a signal that we picked just out of curiosity. We processed it through the initial round of 2 step-by-step meta-analyses, and then we eventually ended up discovering something which we never thought would be responsible for increasing somebody's risk of diabetes if they're on statins. So I think it nicely completes a circle of investigation here. So ladies and gentlemen, I think I probably reached the end of my talk, and I would like to summarize or wrap up the whole theme by saying that there is a very clear and very beneficial role of using systematic reviews and meta-analyses to our advantage in exploiting randomized controlled trial data. As I put forth the cases before you, one of the reasons why we would probably want to do that is to generate robust evidence of a treatment effect, resolve uncertainties in literature, and perhaps of great importance to the humanity, discover harmful effects which were missed before, and maybe of more scientific curiosity to the likes of us, generate new scientific hypotheses. Thank you very much.